Daniela Rodrigues Silva, and on this lecture we will be discussing with you traumatic dental injuries, the complicated crown fracture. I have nothing to disclose. Currently, I am the chair and residency program director of Pediatric Dentistry at UCLA School of Dentistry. So we will be reviewing, some management for complicated crown fracture. First case, 13-month-old female fell the night before at home. The child is very irritable and does not want to eat or drink. So what I want you to think is 13-month-old female. So in my brain, I'm already thinking undeveloped, immature primary teeth. So that's one of the things that related to trauma, you should be conditioning your brain to do the same thing. Mom noticed that the two front teeth chipped. So what is your approach? This is the child, 13-month-old, and you can see number E presents with pulp exposure. Number F, only the medial incisal edge of the crown is fractured. So E and F partially erupted. F and G partially erupted as well. E present with crown fracture and pulp exposure, no caries dentin, very important when we're talking about pulp therapy. No mobility noted on any of those incisors. This is the radiograph that we took the day of. See, open apex, undeveloped primary roots. The exposure. Now, the procedure that we elect for small pulp exposures in traumatic dental injuries is called CVEC pulpotomy or partial pulpotomy. When do we do those? For small and recent traumatic exposure in a non-caries tissue, non-caries tooth, extremely important. You cannot have caries lesions associated with trauma for you to perform this technique, okay? And it can be done for primary or young permanent teeth, especially those with open apex and thin root dentin walls. The tooth, of course, is restorable with an adequate isolation. Rubber dam isolation is paramount for the success. Tooth has a healthy, non-inflamed, and asymptomatic vital pulp. So during the procedure, you will be assessing the bleeding, the color, the viscosity of the pulp, and of course, the ability to achieve spontaneous hemostasis. So what does the technique for CVEC pulpotomy involves? Local anesthesia, rubber dam isolation. And then you use the burr number 330 because the depth of the burr is 1.8 millimeters. That's what you want. You don't want to go deeper than the depth of this burr. And you do not widen your prep. You only go deeper into the pulp. Do not widen because the wider you make that prep, the more you're going to expect of a dentin bridge formation. So keep that in mind. Observe the bleeding. Is it a healthy pulp tissue? Do you have spontaneous hemostasis? Because we are not going to use any medicament that is going to stop the bleeding. You need to count on spontaneous hemostasis. And then the spontaneous hemostasis happen. You dry gently with sodium hypochlorite or sterile water, and then dry that tooth, that fragment, dry that pulp gently. And then you place a thin layer of pure calcium hydroxide. Please do not use Dical or MTA if you have. Place a thin layer in contact with the pulp tissue, and then you cover with a resin modified glass ionomer liner. It can be Vitrabond, it can be Fuji liner, whatever you use in your practice. And restore the tooth with composite. So you finish the treatment, and all of you are wondering, how did she do that in a 13-month-old? As I said before, I use the Mammoose technique a lot. So the mom is lying down in the chair, and she's hugging the child's arm for me, and she's hugging the child's legs with her own legs, and I'm performing my technique.